hypertriglyceridemia, like excess triglycerides, is sometimes considered to be an independent risk factor for cardiovascular disease in some studies. But much like LDL, which is also considered that way in many studies, a lot of things are not adequately controlled for. And in the case of the excess triglycerides, one thing that's definitely not adequately controlled for is insulin sensitivity. So we're going to dig into that now, whether the lipid values that you might see on a higher carb diet are just markers or what they actually reflect about the underlying context, and whether this is actually something we want to be concerned about in terms of cardiovascular disease risk or metabolic syndrome or anything else along those lines. And so we're going to be digging into a study here titled "An Elevation of Triglycerides Reflecting Decreased Triglyceride Clearance May Not Be Pathogenic, Relevant to High Carbohydrate Diets." So they mentioned a number of things here. We're going to start with triglycerides. They state, the researchers observed that endothelium-dependent vasodilation was severely impaired relative to the control group in the hypertriglyceridemic subjects who were severely insulin resistant, but not in those who were only mildly insulin resistant. So again, make that clear. They were looking at subjects with high levels of triglycerides, and the ones who were severely insulin resistant, the function of the endothelium of the blood vessels, essentially, was severely impaired in the people who had high triglycerides and were severely insulin resistant. The people who had high triglycerides and were mildly insulin resistant, there was no impairment in the endothelium-dependent vasodilation, or basically just the function of the blood vessels. So that's the first thing they state here. They then state, this finding supports the conclusion that insulin resistance syndrome, rather than hypertriglyceridemia per se, mediates the endothelial dysfunction and increased coronary risk associated with increased triglyceride levels. So they're just touching on one study here, but again, what they're saying is that basically the high triglyceride levels are just generally an indication of insulin resistance. But if the insulin resistance is not there, and again, insulin resistance just being a global state of impaired glucose metabolism or just generally impaired metabolism, but glucose being the more sensitive one is really the important thing here. So with insulin resistance being a state of generally impaired glucose metabolism, that's responsible for any increase in coronary risk and endothelial dysfunction rather than the triglycerides themselves. They then state another relevant study was published by Cho-Wenchik et al. These researchers assembled a group of severely hypertriglyceridemic patients with an average triglyceride level of 1,914 milligrams per deciliter, characterized as Fredrickson type 5, in whom a marked deficit of lipoprotein lipase, or LPL, activity, rather than insulin resistance syndrome, appears to be primarily responsible for the elevation of triglycerides. So again, just to make this clear, they're talking about a group of people that have a major deficit in LPL activity, and so they have extremely high triglyceride levels. And so we know that this is a state that's, you're not seeing these massive levels of triglycerides just from insulin resistance. This is due to an issue with the lipoprotein lipase. They then state forearm blood flow responses to infusions of acetylcholine and of nitroprusside were measured in this group and in a set of normolipidemic gender-matched controls. The responses of the two groups did not differ. So basically, if you have extremely high triglyceride levels, 1900 milligrams per deciliter, in this case, that was not due to insulin resistance, there was no difference basically in terms of the blood flow response, in terms of circulation and endothelial function between that group and a group with normal levels of triglycerides. And again, what this indicates is that if it's not insulin resistance causing the elevated triglycerides, they themselves are not actually a concern. All they are, in most cases, is a marker of insulin resistance, again, a marker of poor glucose metabolism. They alone are not an independent driver of heart disease or metabolic syndrome. They then go on to talk about this in terms of the size of LDL particles. Remember, I was saying that on a higher carb, lower fat diet, you might tend to see smaller, more dense LDL particles. And they state here, might it not be the case that small LDL particles are just functioning as a marker for insulin resistance syndrome, which is the real mediator of the associated risk? The prospective Quebec cardiovascular study has generated data consistent with this interpretation. Thus, when they examined individuals who had a moderate level of circulating LDL particles, LDL peak particle diameter had no influence whatever on coronary risk. So again, just to make that clear, in people who had moderate levels of circulating LDL, so they still had a decent amount of LDL, it just wasn't elevated, the diameter, the size of the LDL particles had no influence on heart disease risk. They then go on to say in individuals with an elevated level of, or an elevated number of LDL particles and small LDL particle diameter, a 6-fold increase in risk was observed. Arguably, this reflects the joint impact of downregulated LDL receptors and insulin resistance syndrome. If small LDL particles were indeed uniquely pernicious as mediators of endotheliopathy, it is hard to see why LDL size did not matter in subjects with normal levels of LDL particles. So again, we're talking about a very parallel situation here. In insulin resistance, in most cases, you'll see elevated levels of LDL particles. And in that case, and you see, if you see elevated levels of LDL number and they're small, then there seems to be an increased coronary risk. Whereas if you have, quote, normal or moderate levels of LDL and they're small, there's no increase in risk. And if it was just the small LDL particles on their own, that was the risk factor or the driver of the state, you would see it in both cases. The higher or the smaller your LDL particles were, the increase your risk regardless of which group you were in. Now, we also know, based on what we discussed in the lean mass hyperresponder phenotype episodes, that LDL particles and total LDL concentration alone are also not responsible for coronary risk and heart disease risk. They're just markers of insulin resistance in most cases for most people, but there are clearly exceptions. And if you're on a very low carb, high fat diet and you're insulin sensitive, you might see elevated LDL. And again, that's a case where it's not actually associated with anything related to heart disease. So we're saying, again, very similar thing here. And we also see something very similar when it comes to HDL. So the authors state, a low HDL is characteristic of third world societies at minimal risk for coronary disease. Evidently, a high HDL is crucially protective only in the context of risk factors that can induce endothelial dysfunction. Bernard has pointed out the fact that the total cholesterol to HDL ratio of the Tarahumara Indians, whose traditional diet is extremely high in carbohydrates and low in fat, is over 5, a ratio that in Western society would be associated with high coronary risk, yet coronary disease is virtually unknown among this population. So, very similar to what we're seeing with LDL and triglycerides, low HDL is evident in a number of, they say, third world societies, and we're going to talk about some of these native cultures and their lipid values and what we could take away from that. But HDL is generally low in those cases, despite the fact that there's really no signs of cardiovascular disease. Again, we'll dig into this in more detail, but it's worth mentioning. I mean, they mentioned here that the high HDL must just be protective in the context of other risk factors. I think I would say, again, that the assumption that the HDL is inherently protective is much like the assumption that LDL is inherently damaging, or that triglycerides are inherently damaging. The reality being that these are really more so markers or indicators of what's going on. And there are certainly cases where low HDL is associated with really negative outcomes. Like most cases, most people in Western society especially will see that association, but that doesn't mean it's because the HDL is protective and we have a lack of HDL. Rather, it's more of an indicator of the underlying metabolic state. So let's take a look at some native cultures and their lipid values and their different dietary intake, their different macronutrient breakdowns and everything, and also their cardiovascular risk as further evidence for what we're discussing here in terms of the potential lack of concern when it comes to triglyceride levels being elevated and smaller LDL and lower levels of HDL on a higher carb, low fat or lower fat diet. And so we'll start with those Tarahumaras, the Tarahumara Indians of Mexico. And I'm sure they're no longer called Indians, but that's at least how they phrase it in this research, which is from a couple decades back. And this is the population that was mentioned at the end of that last study. We're going to look here at a study titled The Plasma Lipids, Lipoproteins, and Diet of the Tarahumara Indians of Mexico. So a couple of things to note here, a couple of quotes that they share. First, I was looking at the macronutrient intake. So they state that the total fat intake was low, 11 to 12% of total calories. When we look at the rest of the diet, they state the Tarahumara diet was a high carbohydrate diet, 75 to 80% of the total calories, largely starch, and associated with a very high crude fiber intake of 15 to 21 grams per day. The salt intake was 5 to 8 grams per day, lower than the salt intake of most North Americans, although it's worth mentioning that it's a little higher than the sodium recommendations put out by the different associations in the Western world. Moving on here, they state the mixture of corn and beans in the diet provided a protein intake of 79 to 96 grams per day. This was ample both in amount and in protein quality. essential amino acid requirements for human nutrition were more than adequately met by the quantities and mixture of beans and corn protein. Now, I do want to mention here, I'm not suggesting this as an optimally healthy diet. This is far from what I would recommend. Again, you can refer to the Energy Balance Food Guide for more information there, and also prior episodes that I can link back to where we've discussed the foundations of a bioenergetic diet. I would certainly not recommend this, but it's worth noting they're on a very high carb diet, 75 to 80% of total calories, around 10 to 12% total calories from fat. And so we're looking at about 15% protein, give or take. And we can look here at the at table 2, which is titled as the cholesterol and triglyceride content of the different lipoprotein fractions of the Tarahumaras. And we see a few different things here. So when we look at the averages throughout the total sample or throughout the adults, we'll just use the total sample. We see very high, or not very high, but we see elevated levels of triglycerides at 148 milligrams per deciliter. Again, this is right at the border of what's considered high from most, for most lab ranges. Normally, they'll say 150 is really the cutoff where you're talking about high triglycerides, but we're basically right there. And many people would suggest that you don't want your triglycerides above, let's say, 100. But so their triglycerides average around 148 milligrams per deciliter. They do tend to have relatively low LDL, largely due to not only the fact that their fat intake is very low, but also that their fat is very low in saturated fats. Again, not something I would generally recommend, but their LDL looks like the average is around 87 milligrams per deciliter. And their HDL is very low. So the average is 25 milligrams per deciliter of HDL. And normally that's recommended to be at least above 40. But again, many people in the alternative world want it above 50, above 60. And we'll talk about this really clear associative risk between low HDL and cardiovascular disease and vice versa. But again, we're seeing a population here that has no signs of cardiovascular disease. By all signs, they're considered extremely healthy. And their HDL is very low, triglycerides are relatively high, and in this case, the LDL is on the lower end as well. Or I guess I should say kind of moderate end. So that's the Tarahumaras, but there are a couple others that I think are worth getting into here. The next one is the Tukisenta. So we have a study here titled Epidemiological Studies in a Total Highland Population, Tukisenta, New Guinea. And this quote states, a comprehensive survey of cardiovascular disease was carried out on 779 persons over 15 years of age. Carbohydrate provided more than 90% of caloric intake, and the consumption of protein and salt were about 25 and 1 gram daily, respectively. Drinking water was soft, the population was lean, physically fit, and in good nutritional state. There was no increase with age in mean blood pressure, serum cholesterol, fasting blood glucose, or adiposity. Glucose tolerance was, I'll actually just pause here. So we're seeing a very high carb diet, more than 90% of total carbs, a very low protein, very low salt diet. Again, definitely not something I recommend, but it's interesting to see what the outcomes are here and what the effects are on the lipids as a representation of what we discussed earlier in terms of the metabolism or the metabolic state that underlies different lipid values. And again, worth mentioning here, very healthy by all accounts, no signs of cardiovascular disease, no general increases in blood pressure, no increases in fasting glucose, no increases in adiposity, meaning no weight gain with age as well. They're generally lean, physically fit. So this is nothing like what we see in the standard Western population. Yet many people like to blame that on carbohydrates, but as we see here, it's definitely not that simple. And it's not just due to an increased activity in these populations either, which we'll get to with the last group here. But continuing on with this quote, they state glucose tolerance was high, and they actually did some glucose tolerance tests with these different populations, and they're pretty profound how much better glucose tolerance they have compared to other kind of Western populations. They're extremely glucose tolerant, extremely insulin sensitive. They have very, very good glucose metabolism. So they say glucose tolerance was high. The average fasting serum triglyceride level was 142 milligrams per deciliter. Serum uric acid levels were not high. So I'll just pause here. This is something else that's often suggested in the kind of anti-low carb crowd, which is that carbohydrates will excessively increase uric acid, which has all of these downstream negative effects. we talked about this in a couple of episodes, why this is really not the case. And in order to create a state with elevated uric acid levels, you basically need people who are insulin resistant, who are given hundreds of grams of pure fructose in a day, who are not allowed to move or exercise a normal amount. They're forced to be sedentary. Only then do you really see increases in uric acid. And even then, it's more of a protective mechanism than anything else. Again, not something ideal, but not really something that happens other than really, really extreme states that are generally not seen in the vast majority of the population, maybe except for people who are dealing with type 2 diabetes, are very overweight, are very sedentary, and are drinking massive amounts of soda in a day, although even then you're getting the glucose with the fructose, which helps to mitigate any increases in uric acid anyway, since many times they're endotoxin related due to having pure fructose without glucose, not absorbing it well, feeding bacteria, and increasing uric acid. So in any case, we spent a couple of episodes discussing why this is really not any concern for someone eating a healthier high-carb diet, even really an unhealthy one. It's not driven by the carbohydrates themselves or the sugar itself. So in any case, in this population, again, super high-carb diet, their glucose tolerance is high, average fasting triglyceride level was 142 milligrams per deciliter, serum uric acid levels were not high, pipe smoking was common, no diabetes or gout were found, again, things that are suggested to be caused by high-carb intake. There was a low prevalence of diagnosable cardiovascular diseases, and they were looking at hypertension, valvular disease, cardiac decompensation, and cerebral and peripheral vascular disease. They also state ischemic heart disease was rare, if not absent, as indicated by resting and post-exercise electrocardiograms. So by doing as many tests as they could at the time to identify their state of cardiovascular health, there was no indication of anything when it comes to they say diagnosable cardiovascular disease, very low prevalence. And this is all compared especially to Western populations. But again, a suggestion that super high carb diet is not a concern when it comes to cardiovascular health, but also high levels of serum triglycerides, in this case at 142, is not alone a driver of the cardiovascular disease risk. Now, the last population we're going to look at here is the Kitavans. And the Kitavans are interesting because they are also on a very high carb diet, but they're also on a high saturated fat diet, which changes things up a little bit. So we're going to look at a study titled Determinants of Serum Triglycerides and High Density Lipoprotein Cholesterol in Traditional Trobriand Islanders, the Kitava study. So we're going to look at their diet first, where they state tubers such as yams and sweet potato are dietary staples supplemented mainly by fruit, fish, coconut, and leafy vegetables, and the intake of Western food is negligible. According to our estimates, the percentages of energy from protein, fat, and carbohydrates are 10, 21, and 69% in Kitava. The estimated intakes of saturated, monounsaturated, and polyunsaturated fats in Kitava are 17, 2, and 2%. Respectively. So what we're looking at here is a diet containing 69% carbohydrates, 21% fat, and 10% protein. Again, this is on the low end of fat that I normally recommend. It's a bit low on protein for what I normally recommend, but I would say better, at least, or closer to what I would recommend compared to the prior two groups that we've looked at. And of the fat intake, 81% is coming from saturated fats because the total amount of fat they're getting in their diet is 21%. And that includes 17% saturated fat, 2% monounsaturated, and 2% PUFA. So they're on a generally very low PUFA diet and a very high saturated fat diet. And when we look at the lipids here, we see a couple of things. And we've got two tables, one looking at the lipid values in men and the other looking at women. For the men, we see total cholesterol levels averaging 181 milligrams per deciliter. We see triglycerides averaging 151 milligrams per deciliter, so elevated here, again, right at the border. We see HDL at 43, LDL at 108, and we also see insulin at 4.0. So the LDL here is clearly increased relative to the other two populations we looked at, and the HDL is also low, like those prior populations. As far as the women, their cholesterol values are similar. Their total cholesterol is 224 milligrams per deciliter. Triglycerides are a little lower at 115 milligrams per deciliter. HDL is at 46. LDL is higher at 155, and insulin is at 4.8. So a couple of things that we see here in both groups, we see low levels of fasting glucose and low levels of insulin, both of which indicate very good insulin sensitivity. Again, maybe some would say despite their 69% dietary calories coming from carbohydrates. Of course, and I'll link back to some episodes where we've talked about this, but high-carb diets don't cause insulin resistance, as is evidenced here and by many other studies and populations. But again, we see very good carbohydrate metabolism here, very good insulin sensitivity. But in terms of the lipoproteins, in terms of the lipids, we see elevated triglycerides more so in the men than the women, but again, relatively elevated, much like those other two populations. We see relatively low HDL, and we see slightly elevated LDL, especially compared to those last two populations. And this is largely due to both slightly higher fat intake and also that fat largely coming from saturated fats. But again, like those other populations, this is a group that's in fantastic health. And they state that here in this quote, where they state, however, although the Kitavans are apparently free from overweight, hypertension, hyperinsulinemia, hyperleptinemia, cardiovascular disease, and malnutrition, the population means of triglycerides and HDL cholesterol are not favorable in comparison with those of Caucasians. So again, free of overweight, high blood pressure, high insulin, which is a sign of insulin resistance, high leptin, cardiovascular disease, and malnutrition, despite having elevated triglycerides and low HDL. And they mention also, because this is something that I hear so often, is yes, carbohydrates are fine as long as you're incredibly active or if you're young. Now, in these different populations, even with age, they're still extremely healthy. So it does not support the fact that you should reduce your carbohydrate intake as you age or you're not as carbohydrate tolerant. Really, it's just a question of what's going on metabolically and what types of carbohydrates are you eating, what else are you eating, what else are you doing in your life. But on the physical activity side, and this is the case with many of the native populations, the Kitavans are not particularly active. It states the level of physical activity of Kitavans was roughly estimated at 1.7 multiples of BMR, of basal metabolic rate. And this is considered to be around average for Western men and women as well. So they're not actually any more active than their Western counterparts. And then they state in conclusion, despite the fact that cardiovascular disease seems to be absent in Kitava, triglycerides were related to non-HDL cholesterol, HDL cholesterol, and ApoA1, the ApoA1 to HDL-C ratio, in an identical manner to that observed in Caucasians, while conversely, neither the level of triglycerides nor HDL cholesterol was associated with markers of insulin sensitivity. Again, it just comes back to the central thesis we have here, which is that in the Western population, in general, elevated triglycerides and low HDL is happening due to underlying insulin resistance, meaning due to underlying metabolic pathology, where our tissues are not effectively converting the food that's coming in into energy. That is not the case in these populations eating higher carb, lower fat diets. Rather, it's the result of other mechanisms like having very low stress hormones, low levels of free fatty acids, low levels of fat utilization leading to low levels of LPL or lipoprotein lipase. And you basically have these similar markers that are even related to each other in a very similar way, yet they're not associated with insulin sensitivity, and they're also not associated with cardiovascular disease risk. And that's really what the question comes down to. And again, a very, very parallel phenomenon here as to what we see in the lean mass hyperresponder phenotype. So in conclusion here, if you're shifting over to an energy balance approach, and let's say you're coming from a low carb diet and you're seeing that your triglycerides have come up a little bit, your HDL has come down and your LDL has come down, is that a sign of cardiovascular disease risk? Is that a sign of metabolic syndrome? Is that a sign that you're doing something wrong? And the short answer here is no. When we look at the data, when we look at the physiology, when we look at the mechanisms, that's not what's actually going on here. Instead, it's just the product of a shift in the metabolic state, a shift toward using more carbohydrates and less fat, shift toward downregulation of the stress hormones. And in the case of insulin sensitivity, not at all associated with cardiovascular disease. If you enjoyed that clip, you'll definitely want to download the free Energy Balance Food Guide. The Energy Balance Food Guide will help you determine exactly what to eat to optimally support your metabolism and help you lose weight, improve your digestion, get amazing sleep, boost your energy, and so much more. The food guide makes it extremely easy to get started with a bioenergetic approach to optimizing your health. So head over to jfeldmanwellness.com/guide to download your free energy balance food guide.